بالجميع. Our lecture today, neonatal hyperbilirubinemia, or neonatal jaundice. So important and common condition that may be presented most of the newborn. More than 80% or even 90% of newborn may develop neonatal jaundice. Neonatal jaundice is a condition characterized by excessive concentration of bilirubin. In fact, we have two types of neonatal jaundice. The most common, unconjugated or indirect, which can be physiological or pathological in origin. So, unconjugated jaundice may be pathological or physiological, while conjugated or direct jaundice, which always stem from the pathological cause. So, presence of direct jaundice in the newborn indicate a serious permanent condition that, of course, may complicated later on. Both types, and most common with unconjugated, may lead to the neurotoxic effect. Neurotoxic effect that is in case of kernicterus. Here we can take a general idea about the bilirubin metabolism. Bilirubin is a bile pigment formed from the degradation of the hemoglobin, usually derived from the live active red cell, is about 70%, and about 25% from the ineffective red blood cell that killed before maturation. As we say, bilirubin results from destruction of the hemoglobin by enzyme that's called heme oxygenase that converts hemoglobin to the biliverdin. Heme oxygenase converts hemoglobin to the biliverdin. And by the way, the biliverdin will be converted to the bilirubin by action of biliverdin reductase enzyme. Bilirubin or biliverdin reductase enzyme. So, biliverdin reductase enzyme converts biliverdin to the bilirubin. Then the bilirubin should be combined or connected to the albumin, of course with certain receptors. After that, bilirubin that bind to the albumin transfer to the liver. And by the action of glucuronidase enzyme in the liver, we convert indirect bilirubin or indirect jaundice to the direct jaundice that can be excreted by the bile. Because neurotoxicity may follow a high level of unconjugated bilirubin. So our job to convert unconjugated to the conjugated that easily excreted by the bile to the intestine. So glucuronidase enzyme, so important step in conversion of indirect to the direct jaundice. In the intestine, the conjugated bilirubin may stay a long time. If this happens, we have intestinal glucuronidase enzyme that may be convert the indirect again, to convert the direct again to the indirect and return back to the liver. This is called enterohepatic circulation. So enterohepatic circulation add more burden to the already present indirect bilirubin. So this is simply bilirubin metabolism. Besides that, we have a lot of bacteria that may convert bilirubin to the urobilinogen, acetylchobilinogen that excrete in urine and stool in frequencies. So important to remember this pathway of the bilirubin metabolism. In fact, newborn delivered with a lazy transferase, glucuronidase enzyme. So this fact indicate why the neonate develop jaundice in comparison to the adult. And even the premature baby may suffer more because late activation of glucuronidase enzyme. So premature may suffer more mature newborn. Physiological jaundice, from its name, due to some event that consider within normal process. So it's a physiological. In fact, it's a common cause of hyperbilirubinemia among newborn. This is diagnosed by exclusion. After careful evaluation, has ruled out the other more serious cause of jaundice, such as hemolysis, infection, and metabolic disease. So, as we say, most of the newborn, up to 80% of them, develop jaundice after birth. If we consider this physiological jaundice, it should involve in certain criteria. So, physiological jaundice, its clinical presentation should be after the first day. First day jaundice, of course, pathological, but after that, considered physiological in most of cases. Second criteria, an increment in total serum bilirubin concentration, not more than 5 milligrams per deciliter per day. So daily increment not exceed 5 milligrams. Total serum bilirubin concentration, of course, less than 13 milligrams per deciliter in term, and about 15 milligrams per deciliter in preterm. And important that direct bilirubin of less than 0.2 milligrams per deciliter all the time. So level of bilirubin even in physiological jaundice more in the preterm. Why? As we say, due to lazy glucuronidase enzyme in the liver. Persistence of clinical jaundice for less than 1 week. If it exceeds this period, of course, consider pathological. The most important thing for us, the well-being of the liver should be good. If not, it's maybe not physiological. So opposite to the physiological, and this is an important subject that we can deal with it, pathological jaundice. Jaundice, consider pathological if the time of appearance, duration, or pattern varies from that of physiological jaundice. The greatest risk associated with indirect jaundice is the development of bilirubin-induced neurological toxicity, which typically occur with high indirect bilirubin levels. So, our job to reduce and control on the increment of the jaundice to the level that not cause kernicterus or neurological damage to the new growing brain. This is the most important our job. In fact, development of jaundice depend on level of indirect bilirubin. High level may cause kernicterus. Duration of exposure to bilirubin elevation. So you should interfere immediately in this case to prevent more exposure to the high jaundice or high bilirubin. The cause of jaundice play an important role in kernicterus. For example, hemolytic may cause rapid toxicity of the brain. Infant well-being should be all the time taken in consideration. Here we can talk about important non-physiological causes of indirect jaundice. Hemolyticity of the immune etiology, like fetal maternal blood group incompatibility and RH, and non-immune like spherocytosis, hemoglobinopathies, like alpha thalassemia or red blood cell enzyme D6PD deficiency as example. Extravascular blood loss and accumulation in encephal hematoma that we talked about before. Increased enterohepatic circulation due to the intestinal obstruction. As we say, presence of direct bilirubin in the intestine activate the intestinal glucuronidase enzyme that converts direct bilirubin again to the indirect and then add more burden on the liver for protection of glucuronidase enzyme. Breastfeeding, of course, associated with poor feeding, that important cause for jaundice. Disorder of bilirubin metabolism like Gilbert syndrome and Krieger-Najjar, important. Metabolic disorder like hypothyroidism. In fact, hypothyroidism causes indirect, sometimes little increment in direct, so this may cause mixed, but mostly indirect due to lazy enzyme. As you know, in hypothyroidism, all the body metabolism inactive, including the liver enzyme. So conversion of indirect to the direct may be delayed. Here we talk about important jaundice that relate to the breast feeding. In fact, we have breast milk jaundice and we have breastfeeding jaundice. Breast milk and breastfeeding. There is some difference that should be kept in mind. Breast milk jaundice develops in turn infant after the 7th day with a maximum concentration as high as 10 to 30 milligram per deciliter, so a wide range of increment in bilirubin. Of course, this may be continue for a few weeks. If you want to reduce this type of jaundice, you can stop breastfeeding just for 2 days. The level will be fall rapidly. Although uncommon, kernicterus in rare cases may follow a such type of bilirubin. The cause behind the breast milk jaundice is unclear, but may be due to glucuronidase enzyme. Glucuronidase enzyme that we talk about, of course, intestinal glucuronidase enzyme that converts direct to the indirect and increase the effect of enterohepatic circulation that, as we say, add more burden on the liver. Late jaundice associated with breastfeeding should be distinguished from the early onset known as breastfeeding jaundice. Breastfeeding jaundice, which occur in the first week and may be a result of decreased milk intake or dehydration. So, if we make a simple comparison between the breast milk and the breastfeeding jaundice, breast milk may be due to glucuronidase enzyme, while breastfeeding due to low intake or dehydration. Breastfeeding may occur after 2 or 3 days after birth, while breast milk may present later on and that continue more than few weeks. So keep this possibility in mind, this possibility of 2 different issues regarding breast milk or breastfeeding. Important metabolic cause for indirect bilirubin, a serious rare autosomal recessive, of course it's inherited, a permanent deficiency of glucuronidase transferase that result in severe indirect jaundice. So, glucuronidase transferase enzyme, we say it's an important step in conversion of indirect to the direct. Here in this condition, missing. We have 2 types. Type 2, response to the enzyme induction by phenobarbital, producing elevated enzyme and reduced bilirubin level, while type 1 does not respond to the phenobarbital and manifests as a persistent indirect jaundice that may lead in kernicterus in absence of hemolysis. So, type 1, autosomal recessive, complete absence, type 1, complete absence of glucuronidase transferase enzyme. While type 2, we have a partial absence of glucuronidase transferase enzyme. So type 1 may benefit from drug-induced liver enzyme, drug-induced liver enzyme like phenobarbital. So phenobarbital starts to induct the already present glucuronidase enzyme in the liver, while type 1 we have a complete absence of the enzyme. Keep in mind this possibility. If we have a high level of indirect bilirubin in absence of hemolysis, you should think about Crigler-Najjar syndrome. Crigler-Najjar syndrome. As a general idea, we have a lot of hemolysis in the presence of indirect bilirubin. But if the event that indicate absence of hemolysis, we think about Crigler-Najjar. Other conditions that give us indirect, of course, later on, not in the newborn in most of cases, that is Gilbert disease. Gilbert disease. Here we talk about summary of the jaundice that may present in the first week. Important for you, if someone asks you, what are the causes of jaundice in the first week? your answer, first you talk about physiological jaundice. As we say, most of newborn develop as such jaundice. Second, ABO and RH incompatibility. Concealed hemorrhage as kefal hematoma, sepsis, breastfeeding jaundice, Kriegler-Najjar, urinary tract infection, and polycythemia. Causes of jaundice after first weeks. Breast milk jaundice, of course not breastfeeding jaundice. Breast milk jaundice, septicemia, bile duct atresia, neonatal hepatitis, galactosemia, hypothyroidism, cystic fibrosis, inborn error of metabolism. So, sometimes after this introduction of indirect and direct bilirubin, ask you why the newborn develop jaundice? Why the newborn develop jaundice? First, because of the lifespan of the erythrocyte shorter than usual, 90 days rather than 120 days. This is most important. Secondly, the RBC mass in the newborn, of course, more than other age groups. This is important, secondly. So, we can inform you about the peculiarity of the jaundice in the newborn. Peculiarity, because jaundice has its peculiarities in a newborn. Why? In the neonate, the bilirubin level may reach a high level that never to be reached by any other age group. This is number one and important. Number two, most of the newborn develop jaundice for the cause that we mentioned. Number three, and this is the most important, high level in the newborn can cause severe brain damage, that may be not caused by any other age group. So keep these peculiarities of jaundice in the neonate. So the most serious net result of uncontrolled high level of bilirubin is kernicterus. Kernicterus, by definition, is severe neurological condition associated with a very high level of unconjugated bilirubin in the blood. Unconjugated, not conjugated. What are the areas that affected? Of course, we have a yellow staining of the basal ganglia and hippocampus, which is accompanied by widespread of cerebral dysfunction. Of course, if we don't interfere immediately, we have a permanent damage, and on the last, we receive a crippled human being. Important to know what are the causes of such serious, important, preventable, of course, condition. Kernicterus occur when free bilirubin crosses the brain barrier and enter the brain cell. Normally, an accompanied bilirubin is bound tightly to the albumin, which prevent bilirubin from crossing the blood-brain barrier. Free bilirubin exists. Free bilirubin exists when this amount of unconjugated bilirubin exceeds the binding capacity of the albumin. As we mentioned in the metabolism of the bilirubin, after formation of bilirubin immediately, this bilirubin should be attached and bind to the albumin, and both of them should be converted or transferred to the liver, and at that time, glucuronate transferase enzyme take its action. But if we have a little albumin, so in this case we have a free bilirubin without attachment to the albumin. At this point, the free bilirubin can cross the blood-brain barrier and cause a lot of damage. So, important in this point to avoid certain conditions that increase the free bilirubin level. Bilirubin also may enter the brain at a low concentration owing to the displacement from the albumin binding site by another compound, sulfa drugs, as in the marked trimethoprim, which lead to an increased free bilirubin concentration, or because of disruption of the blood-brain barrier by sepsis, asphyxia, acidosis, or effusion of hyperosmolar solution. Few words about certain drugs that increase the level of free bilirubin. Sulfa drugs or other drugs may make a competition with albumin for its receptor. So these drugs may attach to the albumin and make more free bilirubin in the circulation. So sulfa drugs take the receptors instead of bilirubin. So bilirubin will stay high and cause more brain damage. Kernicterus cause a complex of neurological symptoms, including, of course, early and late. Early may present with lethargy, hypotonia, irritability, poor motor reflex, and poor feeding. If we not interfere in this stage, our baby may present with other, like bulging fontanelle, epistatonic, post-tronic, pulmonary hemorrhage, fever, and seizure. Infant with severe cases of kernicterus die in the neonatal period, while survivor infant may develop nerve deafness, chorioathetoid, cerebral palsy, mental retardation, and discoloration of the teeth. So all newborns that develop a high level of jaundice should be followed for assessment of hearing, vision, and other intellectual abnormalities. Kernicterus, as we say, it's important. Why it's important? Because it's a prevented condition. How we prevent? Of course, by avoiding a high indirect bilirubin level and avoiding condition and drugs that may displace bilirubin from the albumin. Keep in mind, early sign coagulation may be reversed by immediate exchange transfusion. So if you have a risk factor of a high level of kernicterus with presentation of early sign or symptom occurrence, you should interfere immediately. Treatment of jaundice. Regardless of the cause, the goal of therapy is to prevent neurotoxicity related to the indirect reacting bilirubin. So, important to keep this in mind. This is the main our job. We start with the simplest type of therapy, phototherapy. Of course, before phototherapy, you should inform the family that good feeding play a role in reduction of level of bilirubin. So you should activate and initiate early feeding. So if the level of jaundice more than physiological, we start with different line of treatment, starting with phototherapy. Is effective and safe method for reducing indirect bilirubin, particularly when initiated before serum bilirubin increase to a level that may be cause carnivorous. Intermittent phototherapy is begun when indirect level exceed 16 milligram per deciliter. In a premature infant, where bilirubin is at a lower level, should be start early because we expect that the newborn may develop a high level for a more duration. Both blue and white lights are effective in reducing bilirubin level. To be continued with phototherapy, what's the action of phototherapy? Is a photochemical reaction producing the reversible, more water-soluble isomers of indirect bilirubin. This isomer can be secreted by passing the liver conjugation system or exceed in the urine. So the action of phototherapy not convert indirect to the direct. Never. Its action by convert the indirect to the safe isomer that may be secreted easily. Because phototherapy may require few hours to have a measurable effect, it must be started at bilirubin level below those indicated for exchange transfusion. The therapeutic effect of phototherapy depends on. So you should be aware about these facts. First, light energy and effective wavelength should be 425 to 475 nanometer wavelength. The distance between the light and the infant, not more than 20 cm. The surface area of the exposed skin, you should net the neonate from its cloth to make more surface area to be exposed to the light. Rate of hemolysis and metabolism and excretion of bilirubin should be taken in consideration. Of course, anatomy of therapy not free of complication, but of course most of them complications that follow phototherapy is so simple. First, increase in soluble water loss, and that causes dehydration. So keep this in mind, so we can increase the feeding. Micropapular rush, that's maybe transient and not harmful. Lethargy and masking of cyanosis, nasal obstruction by eye pads, and potential retinal damage. Loose stool, but not diarrhea. Brown's baby syndrome in the infant with direct jaundice. So keep in mind, phototherapy as one of the most important therapy in indirect bilirubin. Direct bilirubin, what's its level? Not benefit from the phototherapy and may cause bronze baby syndrome. So keep this in mind. Keep this in mind. Other important line of treatment in high bilirubin, intravenous immunoglobulin. Of course, not all patients, just for immune hemolytic disease. Immune hemolytic disease, as in ABO or RH incompatibility, before reaching the level that need exchange. So intravenous immunoglobulin, not for all patients. Metalloporphyrin is important, new drugs that can be used. Of course, single ion dose on the first day of life may reduce the need for subsequent phototherapy. The proposed mechanism is competitive enzymatic inhibition of rate-limiting conversion of heme protein to biliverdin. Of course, heme oxygenase enzyme. As we say, in the metabolism of the bilirubin, after the destruction of the hemoglobin, the heme can be converted to the biliverdin by action of oxygenase enzyme. Here, metalloporphyrin activates this enzyme, and as a result, we have a less biliverdin and then less bilirubin. Can be used for all types. Exchange transfusion, so important operation that can prevent serious sequelae of high bilirubin. Exchange transfusion used in hemolytic disease because this condition cause a high level of bilirubin. What's the action of exchange transfusion? First, remove the bilirubin from the intravascular space, remove unbound antibodies that initiate the hemolytic process, remove affected red blood cell, and correction of anemia. The procedure of exchange transfusion should be done under complete aseptic technique, and you perform this when the serum bilirubin increases more than 20 mg per deciliter or more. The specific bilirubin concentration that require treatment varies with gestational age, the cause of jaundice, and the presence of other medical conditions. So we didn't have a fixed number of bilirubin. It depends on the level on other variables. Here we have practical point to decide which newborn with a high level of bilirubin need exchange transfusion. So a level of 20 mg for bilirubin is the exchange number for infant with hemolysis who weigh more than 2 kg. And a level more than 10 mg per deciliter, consider a number for exchange in the newborn that weight more than 1 kilogram after birth. Asymptomatic infant with physiological, in fact, here exaggerated physiological or breast milk jaundice may not require exchange transfusion unless in diachlorine exceed 25 milligram per deciliter. The exchangeable level of bilirubin for other infant may be estimated by calculating 10% of the birth weight in gram. So, the level infant weighing 1.5 kilogram would be 15 milligram per deciliter, according to the rule of thumb. External transfusion is usually performed through the umbilical catheter in the vein to the distance no greater than 7 cm in a full term and less than for premature. Of course, insertion of the umbilical catheter to the vein, not to the arteries, because here the vessel that present in the umbilical sac composed from 2 arteries that come from terminal iliac and 1 vein that pass the blood to the portal system and then to the right atrium. The exchange should be carried out over 45 to 60 minutes, collectively speaking, as 1 hour, with aspiration of 20 ml of infant blood, alternating with infusion of 20 ml of donor blood. So, from the start, we aspirate 20 ml of infant blood and then give 20 ml of the donor to the infant. Take its blood and give it donor blood. Of course, 20 ml not fixed, depend on the weight and maturity of the newborn. 5 to 10 ml may be indicated in sick or premature or low weight infants. What is the type of blood that should be given? As we say, most of cases that need extra transfusion follow the hemolytic cause like RH or IBO. So RH hemolysis of the newborn need group O RH negative. Group O RH negative. Why group O? Because these RBCs do not have a major blood group antigen, so that are not hemolyzed by maternal antibodies that may still be present in the infant circulation. If RBCs are made available before delivery of the sensitized infant, the RBCs must be RH O negative and cross-match, of course, with the mother. If the RBCs are sourced after delivery, the RBC must be cross-matched against infant. So before delivery, matching with the mother, and after delivery, matching with the baby. So, simply talking, we should give O blood group with negative RH and should be crossed with the RBC of the infant. RBC of the infant. Keep in mind, RH negative, you should give RH negative O blood matched with the infant after birth, of course. In ABO incompatibility, use group O by RH specific RBCs. So RH here not negative And so these infants can use O blood group O positive by RH of the baby, the same RH of the baby, not RH of the mother as a case in RH negative. Again, O blood group contain low level of antibodies and lack antigen that could trigger any circulation of maternal antibodies in the newborn. Important for you to know what is the amount of blood that should be exchanged in any infant. You should memorize this question. For term or preterm, the same. As you know, we have about 85 ml of blood per kg in the infant. So, question as written in front of you, 85 ml multiplied by 2, multiplied by the weight by kg. Why by 2? Because we exchange the infant at the same operation in about more than two times in the same operation. So we do double exchange transfusion, The amount of the blood multiplied by 2 multiplied by weight in a gram. Infant stomach should be emptied before transfusion to prevent aspiration, and body temperature should be maintained and vital sign monitored. After exchange transfusion, the bilirubin level must be determined at frequent interval every 4 to 8 hours because bilirubin rebound within hours as a result of continued hemolysis or redistribution of the bilirubin from other tissue stock. So keep this in mind. This operation not free of complication. Generally, you can divide the complication for operation itself or complications that result from the blood. But we can classify it as acute, like transient bradycardia, cyanosis, transient vasospasm, especially if you wrongly introduce the catheter to the umbilical artery. Thrombosis, apnea, necrotizing enterocolitis, perforation of the vessel, and metabolic instability, hypoglycemia or hypocalcemia. Late complication, anemia, Gardner-Host disease, inspissated bowel syndrome, portal vein thrombosis. So important condition that easily can be prevented. So you should be aware about this possibility. Few lines about the conjugated or direct bilirubin. Direct jaundice defined as direct bilirubin level more than 2 milligrams per deciliter or more than 20% of the total bilirubin from the total bilirubin. So, if I have a level of bilirubin 10 milligrams per deciliter, so if direct up to 4 milligrams per deciliter, we consider this as direct because 4 milligram from 10 milligram, consider more than 20%. So keep in mind this possibility. Direct jaundice never to be physiological. Direct jaundice follow a serious permanent condition that present later with a lot of complication. So we hope to find indirect jaundice rather than direct jaundice in the newborn. Direct bilirubin is not neurotoxic to the infant, but signified a serious underlying disorder involving the cholestasis or hepatocellular injury. Causes: torch infection, toxoplasmosis, rubella, cytomegalovirus, herpes simplex, metabolic, like galactosemia, bacterial sepsis. Of course, bacterial sepsis can give a mixed type of jaundice, obstructive jaundice, biliary atresia, prolonged administration of intravenous protein solution, neonatal hepatitis, alpha-1 antitrypsin deficiency, cystic fibrosis, inspissated bile from prolonged hemolysis. Diagnosis: of course, in every case of jaundice, you should send for fractionation of total bilirubin level. So you should for conjugated and unconjugated type. Here we have a conjugated type, liver enzyme, bacterial and viral culture, metabolic screen, ultrasound, and sweat chloride for fibrosis, and possibility liver biopsy in undiagnosed cases. So keep the causes that cause direct jaundice in your mind in every newborn that delivered with high level of bilirubin, that is outside of the physiological level and outside the hemolytic cause. Treatment, of course, treatment of direct jaundice directed to the underlying cause, and not need, in fact, phototherapy, not need immunoglobulin, not need metaboloporphyrin, not need exchange transfusion, because the bilirubin here not neurotoxic, even it's result from a serious problem. Any question, please?